Welcome everyone, it's Dr. Hall again. So we're moving on to part 2 of 2 for evidence-based public health. Sorry that my video, anyway. So let's remind ourselves where we left off. So we had talked about how we use data and evidence to inform the public health approach, first by identifying the problem, and some of the ways that we're going to characterize the problem is by looking at incidence, prevalence, mortality rates, all of those things. Then we're going to try to deduce the cause or etiology of the problem, looking at group-wide associations to start, and then looking to answer those 3 questions with our case control studies, looking for association at the individual level, our cohort studies looking for the cause preceding the effect, and then hopefully a randomized controlled trial if we can, where changing the cause changes the effect. But as we talked about, that can be difficult with determining the cause of a health condition because we don't want to purposefully expose someone to something we think will be harmful to them. And then in the second half, we're going to talk about recommendations, implementation, and evaluation. But before we get there, I was thinking about part 1 earlier today and how, we talked about mortality rates and how they can be different in different places. And then I remembered from one of our earlier lectures where we talked about different populations based on their population pyramid, how they're going to have different health conditions of concern at the public health or population level, as well as different mortality rates for certain conditions. So remember we looked at South Africa previously and what a young population they were. So I said, let's look at mortality rates for COVID-19 in South Africa. So in this slide, the United States is green, South Africa is purple, and the United Kingdom is orange. So let me use my laser pointer here. So South Africa is purple, so it's this one here. So you can see that their mortality rates, and these are per million people because I wanted to get rid of that effect of difficulty capturing cases. So you can see they definitely have had fewer people dying. You can also see that their waves came at different times than those of other countries. But then I also want to show you, so you can get a sense from here that they had fewer people dying, but to really see it, you want to look at cumulative for the entire time. So when we look at cumulative death rates, look at this. I mean, South Africa, 1,700 per million people, whereas the United States, 3,200. So we have almost double the mortality rates of South Africa. And there's not a big difference in our vaccination rates between the 2 countries. This is definitely because of the difference in age of the population. We have many, many older people in our population, and older people are at highest risk of death from COVID-19. So I just thought it would be cool to show you that. All right, moving on now in our PERI approach, step 3 is recommendations. All right, so we've identified the problem. We think we've identified the potential contributory cause. So now we have to figure out what to do about it. So recommendations is what would work. Now, again, this needs to be based on evidence. So we need to have studies of interventions, ideally randomized controlled trials, although sometimes we're going to rely on case control studies or cohort studies or observational population data. We're sometimes going to need to rely on other forms of data, but ideally really robust studies and experiments that show us the things that will work and that will make this better. So they need to meet all those same requirements that we talked about before, right? Does it work at the individual level? The cause precedes the effect. Changing the cause changes the effect, all those types of things. But then when we're talking about intervening and we're actually doing something to people, we're intentionally recommending that they do something either on the public health level or clinically, right? Somebody comes into the hospital with a condition, what are you going to treat them with? We have to think about potential harms and the safety of what we're doing. Hippocrates is very famous for saying primum non nocere, which in Latin and translates to first do no harm, right? So you don't want to make the problem worse or give somebody a new problem in addition to the problem you were originally trying to solve, right? So sometimes the cure is worse than the disease. And if you've ever known someone who was treated for cancer, for example, with chemotherapy, you can see sometimes treatments can be pretty rough, and sometimes treatments can even be fatal. So there are always side effects, and so we have to kind of balance benefits versus risk. So let me show you an example with what happened with some of the COVID-19 vaccines around benefit and risk. So this is a data table compiled. This one's a little bit old, but I like the format, so I'm going to use it. The data hasn't changed all that much since then. So what they're looking at here is on the one column, the vaccine efficacy against getting infected, right? And so this was before Omicron, I will tell you that. So it's a little bit different now, although it's getting better with the updated booster. But so 85% protection if you've had both of the doses of either the Moderna or the Pfizer vaccines. And if you had the one dose Johnson & Johnson or Janssen vaccine, 65% protection, right? So efficacy against infection that's really good actually for vaccines. But then the efficacy against hospitalization or death, so severe illness, right? So you might still get sick, but it's not going to land you in the hospital or end up killing you, right? This was really stellar. So 95% for the mRNA vaccines and 90% for the J&J. That's really, really, really good for vaccines. That's really awesome, right? So if you can prevent 90% of people from dying from this illness that otherwise would have died, that's fabulous. Okay, so what about risk? So we've been assessing risk of these vaccines all along. The initial studies of the vaccines were randomized controlled trials where people actually agreed to be injected with placebo or dummy injections that had no actual vaccine whatsoever, and they followed them out in time. Those initial randomized controlled trials, and randomized controlled trials are difficult to do and they take time and they're very expensive, but they did them in about 35,000 people, and they found that there were no significant adverse effects of vaccine compared with placebo. So they looked really, really safe. So we started using them, of course. Now, over time, when instead of giving it to tens of thousands of people, you're giving it to tens and hundreds of millions of people, you start to be able to find side effects that are really rare, right? If they're less than 1 in 35,000, they didn't show up in your randomized controlled trial, so they're really rare, but side effects can always happen. So what we're looking at here is a table of confirmed cases of something called thrombocytopenic thrombotic syndrome. Don't worry about it. What it is a blood clot in the brain. This is really serious. And we saw this start to happen in some people who got the Johnson & Johnson vaccine. So here we can see in people who were 18 to 49 years old, there were 13 cases out of 1.8 million doses, right? So they figured out that the rate of this side effect was 7 cases for every million doses of vaccines administered, right? So then they looked at, this is female-bodied people. They looked at over the age of 50, many fewer, so 0.9 per million. And then look at the male-bodied people, no cases. Right? So there are physiologic differences between female and male-bodied people, and so sometimes we do see certain things happen in one gendered body versus the other, either more frequently or only, right? And so they were like, oh gosh, all right, well, this is a pretty bad side effect. If it happens, in some of these cases, the person died. In others, they suffered brain damage. So we don't want to be causing problems more than we're preventing problems. So what's our risk-benefit ratio? So here was the risk. So then they said, okay, let's look at, based on this data, for every million doses administered, we're seeing a rate of about 7 cases of this weird blood clot. And On the flip side, in terms of the benefits, we're preventing almost 300 hospitalizations, we're preventing 56 ICU admissions, and we're preventing 6 deaths. So even in that age bracket where we saw the highest incidence of side effects, there still is, kind of probably a net benefit, because not everyone who got the blood clot died, right? So if you look at the overall health outcomes of people who get the vaccine versus, and in terms of are they better or worse, they're slightly better off with the vaccine still, right? And then you can see for the different age groups and for male-bodied people, because the incidence of this blood clot side effect is so much lower, the benefits clearly outweigh the risks in these other populations. So the decision was made to say that if you had a female-bodied person who was under the age of 50, that you consider using one of the other vaccines instead, because the mRNA vaccines did not cause this particular side effect. Right? So they're just saying, benefit risk is starting to get kind of close and hard, and we have other good alternatives for people who are at highest risk of this side effect. So use that other one instead. So that's kind of a roundabout way of saying that, we're looking at risk versus benefit, and we want to make sure that what we're doing to somebody doesn't end up causing worse health than the thing we're trying to prevent. One of the ways that we can use kind of a shorthand to describe the situation in regard to the evidence is by rating interventions. So this is a classification scheme that's used by the U.S. Preventative Services Task Force and the Agency for Healthcare Research and Quality. So we have lots of smart people that are working to figure these things out for us, which is excellent. So if we have good quality evidence, that means randomized controlled trials, really well done studies, and we find that the net benefits, so benefits outweigh the risks substantially, then we're going to give that an A rating. We're going to say, yes, it's very clear. It's significantly to your advantage to do this thing rather than to not do this thing. Okay, so A recommendations, we should definitely do those in all people. It's a numbers game. The benefits far outweigh the risks. B rating is if the benefit looks substantial, but the quality of the data is like, well, we just have some case control studies, we have some cohort studies, maybe we have a randomized trial that wasn't controlled or wasn't blinded, right? So we might not have as strong evidence, but there still looks to be a clear significant benefit. We're going to give that a B. Same thing if the benefit is moderate. And we're going to do that even if the evidence is good. If the benefit is moderate, then it's like, well, you probably should do this for everybody, but it's not an A recommendation. Then if the net benefit is small, if it's like, yeah, it looks like this probably helps a little bit, that's a C recommendation. So consider doing this, right? It's probably to their benefit to do this, but we don't have as clear evidence. And then a D recommendation. A D recommendation means you should not do it, right? So the benefits do not outweigh the risks. Either they're equivalent or the risks outweigh the benefits. Finally, the last column down here is insufficient evidence. So that means we don't have enough data. We don't know. Okay, we just don't know. Let me show you an example. We talked previously about the cohort study, the Framingham study that followed people forward over time and saw that people with higher cholesterol levels had higher rates of heart disease. Then I showed you a randomized controlled trial where they looked at using medication to treat cholesterol and saw that it decreased the number of heart disease cases that occurred in those people over time. So this is the summary recommendation from this same agency about whether we should put people on cholesterol medicine. And what you can see is that there's a B rating for people who are aged 40 to 75 if they have risk factors such that their estimated risk of heart disease is 10% or greater in the next 10 years, okay? So we're being very specific here about who we're recommending this intervention for. We're going to come back to that later, right? And then here's just some more narrative description of that. Now, if you have a slightly lower risk, then it's a C recommendation because the net benefit is smaller. You're not at such high risk to begin with. So they're like, you probably should. It's probably a good idea, right? But it's not as strong. And then once you're over 76, there's insufficient evidence. They're saying there's some studies, but it's hard to know. You're probably going to die of something. Sorry to say it, right? But so is it really helping you all that much? Is it worth the side effects and the expense of this medicine and the possible interactions of this medicine with your other medicines that you're probably on because now you're in your late 70s? We don't know. Okay, so it's not saying you can't, but it's saying we don't totally know. So these are examples of how we use those grades of recommendations to get an idea of how good is the data and how big is the potential net benefit. We also do this for treatments. So that was to prevent heart disease, right? Using vaccines is to prevent serious illness from COVID. We also do this for treatments. So this is treatment of non-hospitalized people with COVID. And what you can see is that for people who are at high risk of getting severe COVID, so people who are older or have some of those conditions that increase their risk, including high blood pressure, obesity, heart disease, diabetes. There are lots of conditions that are found to increase your risk, right? Look, they should take Paxlovid. It's an A recommendation, okay? Highly effective, definitely works. Remdesivir, B, right? Not as high. Okay. Oh, and those are the strength. They use a slightly different grading system for the strength of their recommendations, but it's very similar. All right. So I'm going to say, well, what about ivermectin, right? What is the deal with ivermectin? And there was a lot of, sorry, the sun is coming up. It's a lovely morning. All right. So there were lots of, in the beginning, I got distracted. In the beginning, there was a small study that came out of France that said, oh my gosh, ivermectin is super helpful at treating COVID. And people got really excited about it because at that point we were grasping for straws, anything that seemed to work. So they started doing some more studies to say, okay, well, this was a really small study. So let's see if we can replicate your results. Let's see if this is really a true thing or if it was just chance. So subsequent studies have found that using ivermectin in a variety of different doses has no impact on the outcomes of people with COVID-19, like at all, right? So earlier studies, right, or let's see, so more recent studies that were larger, better study design, failed to show clear evidence that it reduces time to recovery or prevents the disease from getting worse, all right? So because it shows that we have no evidence that shows that, no good evidence that shows that it works, and because we have other medications that do work, the panel recommends against the use of ivermectin, okay? Now there's still ongoing trials because if it works, that would be great, right? But we know that ivermectin has side effects. We know that we have other medicines like Paxlovid that are more effective. So we're gonna say, don't use ivermectin. We have something else that does work. We don't know if this works or not, and we know it can have potential side effects, right? So we're not trying to be, mean or anything, right? But we can't recommend something on a public health level if we don't have clear evidence of benefit, right? And we know there are associated potential harms. So that is recommendations. So our next step in our PERI approach is implementation. So how are we going to actually do this? And the three questions we're going to ask ourselves is, when are we going to intervene or implement this? At what stage in possible disease progression or prevention? Who, right? Who are we going to target? So we talked about this in a previous lecture. Are we going to address the highest risk individuals, or are we going to kind of shift the average? And then how, right? So what's our methodology going to be to implement our recommendation and actually make it happen, right? We've identified what we should do. Now, when are we going to do it? Who are we going to do it for? And how are we going to make it happen? So the when question is kind of interesting. So we divide our potential interventions into primary, secondary, and tertiary. Primary interventions are things that we do before somebody actually develops the disease. So it says here, after risk or disease before disease onset. So an example of primary prevention is smoking prevention. So campaigns to encourage people to not ever start smoking, right? Just don't smoke. It's bad for you, right? That is primary prevention. Same thing with, so the next example is safer sex, right? So teaching people about how to have safer sex, making condoms available, freely available, easily accessible. Those things are going to help with primary prevention. So intervening, right? Ounce of prevention is worth a pound of cure. We're going to intervene before this thing even gets going. Secondary prevention is like, okay, either the disease has started a little bit or somebody has a risk factor for the disease, right? But they don't have the full-blown disease yet. That's secondary prevention. So an example of this would be smoking cessation programs. So we have lots of smoking cessation programs that are funded by public health dollars in this country. So quit lines and other ways to help people quit smoking cigarettes, hopefully before then they get lung disease. We can also screen for the early stages of lung disease in people who are smokers and be like, ooh, it looks like you're heading down that path. Let's do something different. That's secondary prevention or secondary intervention. Same thing with testing for STIs or giving someone emergency contraception like Plan B after having unprotected sex. It's like, okay, you already have this risk. Let's try to intervene now and do what we can to stop things from getting worse and progressing to kind of the full-blown condition, which would be an STI or a pregnancy. And then tertiary interventions are things where the disease is already up and going, okay, or the condition is already up and going, but we're going to try to intervene and make it less severe. So treating lung disease that develops in people who are smokers, different options for what to do with a pregnancy that is undesired, treating STIs, those are our tertiary interventions. So that's the question of when, which was our first question. The second question is who, and again, we've talked about this before. Are we going to do this for everyone? Are we going to screen every single person for STIs, right? That would be that secondary intervention, or only those who are most vulnerable, right? So how about maybe only those young people, who we know are having the greatest number of unprotected sexual partners, right? So we might just look at who's most likely, who's at highest risk for the condition, or only those with the greatest net benefit to be gained. So that harkens back to that guideline about cholesterol medicines in people over age 75. They're definitely vulnerable to heart disease, right? But how much benefit are we going to gain from treating someone with a cholesterol lowering medicine if they're already toward the end of their lives, potentially? Right? So then we have to kind of think about that. So the who question becomes important and harkens back to things we've already talked about. The third question is a new one. So how? So how are we actually going to implement these recommendations? We've said you should do these things, or we think you should do these things. The evidence shows that this would be useful. So how are we going to actually make it happen? And we have three options in increasing levels of stringency, let's say. So the first one is information and education. So let's just tell people, hey, you should do this thing, right? So you should wear a mask, you should social distance, you should get a vaccine, right? So all these education campaigns that happen in various ways. And that's kind of our first go-to, right? Is just tell people, hey, it's good for your health if you do these things. People don't always do them. Right? So although this sounds like a great idea, and it is, and it's very important because people should understand what's involved in their health and why certain things are being recommended and what things are recommended, it turns out it's not very effective. So just education alone is one of our least effective options for how to implement something. The next step up is more effective, which is motivation or incentives. So in the state of Wisconsin, actually, there was a period of time where we gave people $100 to get vaccinated. Like we literally did. We gave people $100 to get vaccinated. And that worked. That worked a lot better than, just telling them that they should. I also gave extra credit for my students who chose to get vaccinated. Now I made an alternative assignment for those who felt like vaccination was not for them. They could do a research project on the vaccines instead. So they still had a way to get the extra credit, but those incentives, right? So let's think about, here we are, we're in chapter 2, and I wonder how many of you have actually even opened the textbook yet, right? Now, it's definitely to your benefit to read the textbook. It'll help you understand the material. You'll learn a lot more. You'll do better on the quizzes. And you know those things. You've been informed about that, right? You're a student, you know how that goes. But maybe you need a little additional motivation or incentive. So perhaps for this unit, I'm going to put a question on the quiz that requires you to actually go into the book, right? So that you know how, I know that you know how to get there, right? So motivation or an incentive to do it. Now, those can be really helpful, but they are still less effective than obligations or requirements, or you may think of them as mandates, right? And so during COVID, you got to see all this happening in real time. So, right, so requiring proof of vaccination, right, requiring people as a result of their employment or to go certain places or engage in certain activities, requiring them, forcing them to get a vaccine, right, which is also what we have done with seat belts. We have made it the law that what you do in your car on your own, right, is you are legally obligated to wear a seatbelt. And if you don't wear a seatbelt, then we can fine you or whatever the other implications are going to be. So the obligation or requirements are the most effective, but of course they infringe the most on your sense of personal liberty or autonomy, right? So that personal liberty or autonomy is going to be highest with information and education. Like, here's the information, do what you think is right for you. And in our culture, we tend to value personal liberty and autonomy very, very highly, more so than almost any other society, right? So it's a uniquely American trait. But we have to balance that against the fact that the things that preserve the most autonomy are the things that are the least effective at actually getting people to do what is going to improve their health. So it's a sticky wicket, as they would say. It's a difficult balance to strike, and we have all witnessed the difficulties and messiness of trying to strike that balance over the last several years. So on that note, I just want to share a quote with you from Wendell Holmes, who is a physician and poet and has written many wonderful things. But people in public health are very familiar with this quote, which is, "My right to swing my fist ends where your nose begins." So this is a way for us to help try to strike that balance between personal liberty and autonomy and the effectiveness of the intervention. So when we're looking at the health of a population, we can say, well, maybe you can do whatever you want as long as what you're doing is not harming other people or putting other people at risk. And if you think about a lot of our laws, right, it's like, okay, if you want to go, I don't know, swing a sword around, that's fine, as long as you're not swinging it at another person, right? Then that's battery assault, I don't know, right? So you can get arrested for that. So this is a way that we can try to strike that balance. So when we think about what were the potential harms to others, for example, of somebody not getting vaccinated, and because some people would say, well, it's my choice, it's my body. If I don't get vaccinated, well, then if I get sick, that's my choice. But it actually also impacts the health of the people around you. So I'm just going to share you a couple of examples of that. So again, balancing personal liberty against the goods of others, right? Potential harm to others. So one of the things that we have seen with COVID-19 is that people who are unvaccinated get hospitalized at much higher rates. And so what ended up happening is that our hospitals during surges got overwhelmed. And our ICUs got filled up, our hospitals got filled up, there weren't enough doctors, there weren't enough nurses, and people couldn't get good care. So people who even had non-COVID illnesses, the hospitals were full and there was nobody who could take care of them. So unfortunately, there were lots of stories of people who couldn't get the care that they need because the hospitals were overwhelmed with COVID patients, many of whom, and often most of whom, were unvaccinated, right? So they were using up this resource that then was not available for other people who needed it. So we need to think broadly about the potential harms of the individual choices that we all make, right? So some people were getting really upset about this, right? And saying, well, if you choose not to get vaccinated, then maybe you should choose not to come to the hospital if you get really sick, which I understand the sentiment, but healthcare providers, healthcare workers, we're never going to turn somebody away like that, but it creates this issue. The other issue it created is that we have lost a lot of our healthcare workforce. So it's estimated that up to 20% of our healthcare workforce has retired or quit or left clinical medicine due to the stresses of the pandemic, including people not trusting their healthcare providers and refusing to follow their recommendations. And that's really difficult psychologically when you are working really hard to try to protect people's health, and it's not only not appreciated, but oftentimes met with violence, and there are terrible stories. You probably know about it. Okay, so this is implementation. So those three questions, right, or those three options that we have: education, motivation, or basically coercion, basically mandates and requirements. So then we want to see if it's working. Okay, so this is going to be really important. We've identified the problem and the contributory cause. We've come up with recommendations for things that we think will ameliorate or help lessen the problem. And we figured out how we're going to implement it in terms of when, who, and how with those three different methods. And now we need to see if it's working. So how's it going? So the book uses this re-aim mnemonic, which can be useful. So is it getting where it needs to, right? Are we actually reaching the people that we're hoping to? Effectiveness, so making sure it's helping and not harming. So those ongoing studies of the vaccines are an example, right? So we're continuing to monitor the effectiveness and continuing to make sure that the benefits significantly outweigh the risks. Adoption, right? So maybe we're reaching people, but they're not doing it, right? So maybe we're giving them education about and information about their recommendation, but they're just like, nah, and they're not doing it. Implementation, again, how do we get to the target population? And maintenance, how do we keep it going? So in this country and in this state, we did a pretty good job of vaccination of our highest risk population members, so those people who are over age 65, so they're at highest risk for severe COVID, for example. But our maintenance and our ability to keep that going has not been awesome for lots of reasons, right? Everybody's just tired of it, wants it to be over. I get it. So here's an example of this evaluation. So the state is continuing to keep track of how we're doing in terms of vaccination rates. So this number, less than 20%, is the percentage of Wisconsinites who have received the updated, the fall 2022 booster, which contains protection against the Omicron variants, which are the ones that are currently circulating. So we have really good data that shows that these vaccines are just as safe as the other ones, and really good data that show that they significantly improve your immunity and decrease further your risk of severe illness, because your vaccine from a year ago, if your last vaccine was in 2021, has worn off quite a bit. So just like we get flu shots every year, it's looking like we're likely going to need COVID shots every year, but fewer than 20% of Wisconsinites have gotten their updated booster this year. Now, if we look at the different age groups, you can see we're doing better in the 65 plus folks. So that's good, because they're the people that are at highest risk. Those are the people we most want to get this intervention to, but it's still less than half, right? So we shall see what happens in terms of our hospitalization rates and in terms of our death rates from COVID. We'll kind of see how much the extra protection from this vaccine is really needed or not, right? Maybe your natural immunity plus some previous vaccine doses is going to be enough to prevent our hospitals from being overwhelmed again this winter, or maybe not. I don't know. We'll see what happens. And continue to evaluate, which is the last step. How are we doing? How is it going? All right, so this is our PERI approach to evidence-based public health. Here it is. Now this slide should make a lot more sense to you. So, problem, we want to understand the burden on the course of the disease. We're going to look at incidence, prevalence, mortality, morbidity, other pieces of information to get a sense of what's going on. Then etiology, we're going to try to figure out what's causing it. So first we're going to look for distribution of disease, right? Who is getting it, where, and when, looking for those group associations. And then once we find group associations, we want to explore those further to see if those characteristics are actually contributory causes. So those three requirements about the individual level, the timing, and that changing the exposure changes the outcome. So the three types of studies are case control, cohort, and randomized controlled trial. And then since we can't always get randomized controlled trials, supporting evidence would include the magnitude of the effect, a dose response, so magnitude of effect we're going to see with relative risk, dose response, relationship, consistency, and biologic plausibility. And then just remembering that contributory cause, just because you have a risk for a certain condition does not mean you're going to get it. And just because you don't have that risk doesn't mean you're not going to get it, right? So just remember, it's not a guarantee one way or the other. It just stacks the odds one way or the other. Then we're going to come up with recommendations. Those need to be evidence-based, right? And we grade them according to the quality of the evidence and the magnitude of impact. The thing I didn't put on here that you need to remember too is we need to consider potential harms of the intervention. So it's that net benefit, right? Benefit versus risk, benefit versus potential harms that we need to consider. And then implementation. So how are we going to intervene? Again, assessing harms versus benefits. And we have primary, before onset of the disease or risk factor, like preventing people from smoking in the first place. Secondary, intervening after they've incurred some risk but no actual disease, right? So emergency contraception or smoking cessation. And then tertiary interventions, they already have the disease, but we're going to try to prevent it from getting worse. Who, right? Everyone, highest risk, those most likely to benefit, right? Those are the three different groups we're going to consider. And then we have those three strategies for how. So information and education preserves personal autonomy and liberty the most, but is the least effective. We've got that motivation in between, and then obligation or mandates or requirements, laws are the most restrictive in terms of your personal choice, but they are also the most effective. And then evaluation, is it working, right? Are we reaching the right people? Are they adopting the recommendations that we have made or not, right? Definitely not in terms of the COVID booster vaccine. Those numbers are dismal. Keep watching and making sure that the benefits outweigh the risks. All right, that's it for part 2. Thanks for your attention.